Hello, everyone, and welcome to our module on pleural disease. Before we can talk about pleural diseases, let's talk about what we mean when we use the term the pleura. So the pleura are two layers of tissue that surround the lungs. The first layer is called the visceral pleura. This layer is attached to the lung, and the word viscera means organ, so that's why this layer is called the visceral pleura, because it's attached to the organ or the lung. And then the parietal pleura is attached to the chest wall, and the word parietal comes from a Latin word that means wall, so that's why this layer is attached to the chest wall. And so once you understand that the pleura have these two layers here, then it's fairly easy to understand that the pleural space or the pleural cavity is the region between those two layers. Now, the pleura are lined by a single layer of cells called mesothelial cells, and they normally secrete a small amount of pleural fluid for lubrication of the two layers of the pleura. So later we'll talk about excessive fluid, that's called a pleural effusion, but in normal healthy lungs you can still find a very small amount of pleural fluid, which is there simply for lubrication. Okay, so the first pleural disease or pleural disorder that we'll talk about is a pneumothorax, often referred to by the abbreviation PTX. And a pneumothorax means there's air in the pleural space. And there are two key subtypes of pneumothoraces. They have different pathology, and we'll talk about both of them. First one is called a spontaneous pneumothorax. The second one is called a tension pneumothorax. First, let's talk about a spontaneous pneumothorax. And to understand this condition, let's look at this cartoon on the slide here. So in a spontaneous pneumothorax, a small hole in lung tissue develops spontaneously, and that allows air to leak out of the lungs and fill the pleural space. And when this happens, the lung is going to collapse. And so the side of the chest where the hole in the lung exists is going to become mostly filled with air with the lung tissue compressed way down. And this will be important in a minute when we talk about identifying a pneumothorax on a chest X-ray. There are two subtypes of spontaneous pneumothorax. A primary spontaneous pneumothorax occurs when there's a rupture of a subpleural bleb. Subpleural blebs are small amounts of abnormal tissue in the lungs. They're common in tall, thin, young males, and sometimes they spontaneously rupture, and that's called a primary spontaneous pneumothorax. It occurs in someone who does not otherwise have underlying lung disease. In contrast, a secondary spontaneous pneumothorax occurs in someone who has sick lungs. So these usually happen in older patients who have some underlying lung issue. It could be COPD or some other abnormality that makes the lungs abnormal, and then they spontaneously develop a hole, and that's a secondary spontaneous pneumothorax. So when a spontaneous pneumothorax happens, what does this lead to in terms of symptoms for the patient? Well, first of all, there can be the sudden onset of dyspnea. Remember what I showed you on the last slide? The lung tissue on the side of the lung with the pneumothorax is going to shrink, and that's going to take away a lot of lung area for oxygenation of blood, so patients can develop dyspnea. Sometimes they develop pleuritic chest pain, and if it's a very large pneumothorax, sometimes it can lead to hypoxemia, although this isn't always present. There are some classic findings on lung exam with the stethoscope you should know about for pneumothorax. I talk about these in detail in the video on lung sounds, but first of all, there will be diminished breath sounds on the side of the chest with the pneumothorax, and that's because the lung tissue is collapsed and there isn't air moving in and out of that side of the lungs. There can also be decreased tactile fremitus and hyperresonance to percussion, and these things I talk about in another video. And then the diagnosis is made by chest X-ray. This is a pretty classic example of a pneumothorax by chest X-ray here. These aren't easy to identify if you're not used to looking at them, but once you understand what they look like, they are pretty easy to recognize. If you look over here on the left side of the chest, you can see that all the area where lung should be is filled with these little white wispy sort of things. That's lung tissue. Now, if you look over here on the right side of the chest, you can see that out here in the periphery, we don't have any of those little wispy white areas of lung tissue. And then if you look closely, there's a line right here, and that is the edge of the lung where it has collapsed from the pneumothorax. So all the lung tissue is right in here. Out here we have air filling the pleural space. Search up on Google a couple of x-rays of spontaneous pneumothorax, and you'll get used to recognizing these. Once you know what to look for, they're fairly easy to identify. Let's talk about the treatment for pneumothorax. So if you're faced with a patient with a pneumothorax, the first thing you want to do is administer 100% oxygen. Why is this helpful? Well, the reason has to do with nitrogen. When you give a patient 100% oxygen, it will displace nitrogen from the capillary blood. Let me explain what I mean by this. Normally, when we breathe room air, 78% or so of that air is nitrogen. This means that the blood flowing through our capillaries, although it has oxygen, which is good, we need that for metabolism, it also contains a lot of nitrogen. But if you give a patient 100% oxygen, then eventually you can get the gases in the bloodstream flowing through the capillaries to have very close to zero nitrogen. And that's going to help a lot because the blood will have 0% nitrogen, but the pleural space will still have lots of nitrogen because it filled with air coming from the atmospheric air. So the pleural space has 78% nitrogen in it, but the blood will have close to zero because you're giving 100% oxygen. This creates a gradient, and the nitrogen will be pulled out of the pleural space. It will be reabsorbed and exhaled from the body, and this will cause the volume of air in the pleural space to shrink. And then once this happens, usually the hole in the lung will heal on its own over time, and then the patient can resume breathing normally. When patients have very large pneumothoraces, on the other hand, then you need to do something. In addition to 100% oxygen, you need to put in a chest tube. This is a tube that goes into the pleural space. This is a little cartoon of it here, and it basically sucks the air out and allows the lung to fully expand. This is usually done only for large pneumothoraces that are more than 15% of lung volume. If a patient has a very small one, they usually can be treated with oxygen alone. Okay, now let's move on from spontaneous pneumothoraces and talk about tension pneumothoraces. So these are usually from trauma, and what happens in a tension pneumothorax is air enters the pleural space, but it cannot leave. So to understand this, let's imagine we have a wall of the lungs and a little hole develops here that air can go through, causing a pneumothorax. Well, sometimes this hole has a little flap of tissue like this hanging out. And so air can go out and fill the pleural space, but it can't go back the other way because if it tries to do that, it shuts this little flap. So as a result, every time the patient takes in a breath, they put a little bit more air into the pleural space, and eventually the pressure here in the pleural space is going to get very high. And that's the problem in a tension pneumothorax, the high pressure in the pleural space. So when the pressure builds, it can get high enough to compress veins. Remember, your veins have a relatively low amount of blood pressure, and they can become compressed if the pressure in the chest is higher than the pressure in the veins. This can decrease the venous return to the heart, and in turn that drops the cardiac output. And this leads to a special form of shock called obstructive shock, which I talk about in detail in the cardiology section. So the patient can develop hypotension from low cardiac output. The jugular veins can become elevated. That's because blood can't drain from those veins into the heart, and this is a medical emergency. You need to do an emergent thoracentesis, which is a small hole in the chest, and place a chest tube. And then the patient remains on the chest tube for a day or longer until the hole in the chest heals. And then one sort of special high-yield thing to know about tension pneumothoraces is that they cause the trachea to deviate away from the affected side. Remember, if you look at this cartoon here, you've got all this high pressure on this side that's going to push the lung, including the trachea, over to the opposite side. And that's one of the classic findings in a tension pneumothorax. So this slide has a table summarizing the key features of spontaneous versus tension pneumothoraces. I won't go through this table in detail. It's all the things we just talked about in the last few slides. But these are the things you want to remember about these two types of pneumothoraces for your exams. Okay, now let's talk about atelectasis, which refers to alveolar collapse, basically collapse of lung tissue. This isn't really a pleural disorder per se, but I'm talking about it here because as we just saw, in a pneumothorax, the lung can collapse on the affected side. And the same thing happens in atelectasis, but there is no hole. The lung is collapsing for other reasons. So let's talk about some of the reasons that atelectasis can develop. The first reason is called obstructive atelectasis. This happens when there's obstruction of the airway preventing the alveoli from filling. When the alveoli cannot fill, the old air that's inside them from when they were able to fill will eventually be resorbed, and then the lung tissue in that area will collapse. And there are a number of reasons this can happen in various clinical situations. In patients who have pneumonia, they can have a mucus plug that obstructs the filling of air in a portion of the lung. That leads to collapse or atelectasis. Tumors can do this. Foreign bodies can also do this. Another reason atelectasis can occur is from compression. So if there's some external factor compressing the lungs, this can block the lung from expanding and lead to atelectasis in a section of lung tissue. So you can see this when patients have tumors outside the lungs. You can also see this in pleural effusions. And shown here on this chest x-ray is an example of what atelectasis looks like. I don't think they will expect you to recognize this on your step 1 exam. It's not that easy to recognize if you haven't seen it a number of times in clinical practice. But if you look at this area of white density here at the bottom of the right lower lobe, that's what atelectasis looks like. It basically looks like a small section of white tissue. Some other causes of atelectasis or types of atelectasis are shown in this slide. The first one is contraction atelectasis, often referred to as cicatrization. The word cicatrization means the development of scar tissue, and the reason contraction atelectasis is sometimes called cicatrization is because it occurs due to scarring or fibrosis, either within or around the lung tissue that prevents expansion of the lungs. This can happen for a number of reasons, but one of the classic reasons is sarcoidosis. And then adhesive atelectasis is what happens in babies with the neonatal respiratory distress syndrome when they don't produce enough surfactant. Without surfactant, there's high surface tension. I talk about this in detail in other videos, and the alveoli will collapse. And that's called adhesive atelectasis, usually seen in infants who have the neonatal respiratory distress syndrome. And then finally, probably the most common form of atelectasis that you'll see in the hospital is so-called postoperative atelectasis. So when patients come out of surgery, they can have pain from surgical incisions. They can also be in a relatively weakened state. And as a result, they don't fill their lungs fully. They have a decreased tidal volume. And this can lead to small amounts of atelectasis, usually at the base of the lungs, a very common finding in patients who have just had surgery. Some of the treatments for atelectasis are shown on this slide. The first one is incentive spirometry. That's what's depicted in this photo on the slide here. This person is holding up a spirometer and the patient is taking in a large breath of air. And basically what happens is when the patient breathes in through the spirometer shows their effort. And the patients are encouraged to keep doing this regularly to try and build up their strength at inhaling and to maintain a good effort. This is often done for patients who are post-op so that they inhale fully and expand the lungs, and this can prevent atelectasis. And then sometimes atelectasis occurs in patients who are on a mechanical ventilator. And when this happens, there's a special intervention for atelectasis you can do, and that's called increasing the PEEP. So PEEP refers to positive end expiratory pressure. It's one of the settings on a ventilator, and it's one of the things you can do to try and minimize or eliminate atelectasis. So normally when we exhale, we're blowing out air against atmospheric pressure, which is 0 millimeters of mercury. With PEEP, the ventilator allows the patient to exhale against a higher pressure greater than 0. You could set it at like 5 or like 10. So when this happens, basically when the patient is exhaling and they're trying to push air out of their lungs, they're pushing against a higher pressure compared to the normal 0 pressure that you would experience if you were breathing room air. And because of this higher pressure during exhalation, there's less collapse of the lungs. Basically, a lot of atelectasis occurs during exhalation, and if you think about that, it should make sense to you. You're pushing air out of the lungs, and that's when the lungs are going to collapse if they have a problem. But if you let the pressure be higher during exhalation, then there's less collapse of the lungs. And so this is a way you can manage atelectasis in a patient on a ventilator. Ventilators are very complex. They're not something you need to know for the step 1 exam, but this may come up, this feature of the ventilator called increased PEEP, so that you understand that it can eliminate atelectasis. Okay, next let's talk about pleural effusions. So a pleural effusion is an accumulation of fluid in the pleural space. Remember what I said earlier, there's always a very small amount of fluid in the pleural space for lubrication, but when that amount of fluid expands, that's a pleural effusion. And when effusions in the pleural space get large, they can interfere with breathing. Pleural effusions are usually identified by chest X-ray or sometimes chest CT. This is a picture of what one looks like on a chest X-ray. These are fairly easy to recognize, even at the early med student level. You'll notice on this side here, we've got normal lung tissue on the right, but over here on the left, we have all this white opacification down here at the bottom of the lung fields. That's a pleural effusion. Notice that it doesn't correspond to a single lobe like a pneumonia, like a consolidation. Instead, the fluid is covering multiple lobes of the lung and filling all the way up to the top. That's a pleural effusion. We'll talk later about specific diseases that can lead to the development of a pleural effusion, but before we get to that, you need to understand that there are 2 major types of pleural effusions. One is called transidative, the other is called exudative, and they're distinguished from one another by the characteristics of the fluid in the pleural space, and that's what we're going to talk about now. So to understand the difference between transidative and exudative effusions, you first have to appreciate that in both types of effusions, fluid is leaving the capillaries and filling the pleural space. That's what's causing the accumulation of fluid. So shown on this slide is a cartoon that I go over in great detail in the cardiology section. It describes the forces that control movement of fluid between capillaries and interstitial spaces like the pleural space. And so in pleural effusions, you have fluid moving out of capillaries into the pleural space. So what can make that happen? Well, the first thing that can make that happen is a difference between the hydrostatic pressure P sub C in the capillary and the hydrostatic pressure P sub I in the interstitial space. If PC is greater than PI, then fluid is going to move in this direction out of the capillaries. And so hydrostatic pressure is like your blood pressure. It represents the forces of molecules pushing against the walls of a vessel. And so if the hydrostatic pressure in the capillary goes up and becomes higher than P sub I, then you're going to get fluid moving in this direction. And that's one way you can get a pleural effusion, is if you have a high P sub C that's greater than P sub I. Another factor that controls movement of fluid between capillaries and interstitial spaces is the oncotic pressure. Oncotic pressure, when it gets high, tends to draw fluid towards that area of the body. So if you have a high oncotic pressure, pi sub c, in the capillary, that will tend to draw fluid inward out of the interstitial space. But if you have a low oncotic pressure, pi sub c, in the capillary, then you will get movement of fluid out in this direction. So a second way that you can get movement of fluid out of capillaries into the pleural or interstitial space is if you have a very low pi sub c, less than pi sub I. And your oncotic pressure is basically determined by the amount of protein in your blood, especially albumin. So as we'll see in a minute, in situations where albumin is very low, that can cause fluid movement out of capillaries. And then finally, capillaries have a permeability constant called K. And so if that goes up, that means that leaks or spaces occur between the cells lining the capillary. And so anytime you get increased permeability, then you can get fluid leaking out. Even if the pressures are relatively normal, this process has nothing to do with differences in hydrostatic or oncotic pressures. It has everything to do with increased permeability. So the bottom line here is these three things can cause fluid movement out of capillaries. Make sure you understand this for step one. This is what they're going to want you to know about pleural effusions. So in transidative effusions, you have either high hydrostatic pressure or low oncotic pressure causing the movement of fluid into the pleural space. In contrast, in exudative effusions, those are caused by increased capillary permeability. So remember, these are the three factors here which can cause fluid movement into the pleural space. The first two lead to the development of transidative effusions. The third one leads to development of an exudative effusion. So now that we understand that, let's talk about transidative effusions in detail. So in these effusions, the capillary permeability, the capillary membrane, the K, is normal. There's no leakiness of the capillaries. And because of that, it's very hard for proteins to move out of the capillary into the pleural space. What happens in transidative effusions is you have either a very high P sub C pushing fluid in this direction or a very low P sub C allowing fluid to move in this direction. Basically, something is driving fluid out of capillaries. It's one of these two things. So as a result, you get a lot of water here because fluid is leaving the capillaries, but you have very low protein content in that fluid or in that water. And that's because permeability of the capillaries is intact and proteins can't move out. So this is a key thing to understand about transidative effusions. They're caused by these two underlying mechanisms, and they lead to the development of pleural fluid, which has a very low protein content. So what can cause transidative effusions to occur? Well, the most common cause is heart failure. So in the cardiology section, I talk a lot about heart failure, and in that condition, you get very high pulmonary capillary hydrostatic pressure, and that drives fluid out of capillaries in the lungs, and it fills the pleural space, causing a transidative effusion. Less commonly, you can see transidative effusions when there's very low capillary oncotic pressure. These are situations where there are very low protein levels in the body, especially low albumin levels. So you can see this in nephrotic syndrome, where protein is being lost in the urine, so there's low protein in the capillary fluid. You can also see this in cirrhosis, where the liver is not producing albumin, so there's low albumin. And the treatment in most cases for transidative effusions is simply to treat the underlying cause. Usually you do not need to put a catheter into the pleural space and drain the fluid, because if you simply treat the heart failure, for example, with loop diuretics, or you treat these conditions and improve the protein levels, then the effusion will resolve on its own without need to stick a needle into the patient's chest and drain the fluid. In contrast to transidative effusions, exudative effusions are caused by increased capillary permeability. Just like we talked about a few slides ago, it's super high yield to remember this underlying pathophysiologic cause. So when the capillaries become more permeable, fluid can leak into the pleural space, but so can protein. So as a result, you get fluid accumulation in the pleural space with a high protein content, and that's different from transidative effusions. There are many disease processes that can cause exudative effusions. If you have lung cancer, this can do it. Patients who have pneumonia can get an exudative effusion. This is called a parapneumonic effusion. Sometimes bacteria can get into that effusion, and when that happens, it's called an empyema. ARDS is another classic cause of leaky capillaries in the lungs, and this can lead to exudative effusions. And in contrast to transidative effusions, exudative effusions often require drainage. Especially if they're related to pneumonia or malignancy, they can become infected. So usually these have to be drained. Not always, but in many cases they do. And this is different from transidative effusions, where, as I just said, you usually treat the underlying cause. So what do you do when you're faced with a patient who has a new pleural effusion and you're not sure of the cause? In other words, you're not sure whether it's a transidative versus an exudative effusion. Well, the way you can sort this out is by doing a test called a thoracentesis. It involves inserting a needle into the pleural space so that you can obtain a sample of the pleural fluid. And you send that sample to the lab, and what they usually measure is the total protein content and the amount of LDH. LDH is lactate dehydrogenase. It's a protein marker of inflammation. And the reason it's always measured is because it gets very, very high when there's infection of the pleural fluid. So you can measure the total protein content. This helps you sort out whether or not you're dealing with an exudative or transudative effusion. And then you can also look at the LDH, because if that's very, very high, that suggests an infection. Once you know the total protein content and the LDH content of the pleural fluid sample, you can use what's known as Light's criteria to determine whether it's a transudative or exudative effusion. So Light's criteria says the effusion is an exudate if any of these three things are present. The first one is a ratio of pleural protein to serum protein more than 0.5. The second one is a pleural LDH to serum LDH greater than 0.6. And the last one is a pleural LDH that's greater than 2/3 the upper limit of normal for serum LDH. And you can memorize these if you want to, but if you understand the difference between exudates and transudates, these are very easy to make sense of. Basically, if any of these are present, it means that there's a lot of protein in the pleural fluid. And when there's a lot of protein in the pleural fluid, as we've already discussed, that indicates an exudate. And so the key points to remember about how to distinguish transudates from exudates is that you have very high pleural protein in exudates because the capillaries are leaky and they're letting protein escape. And you have very low pleural protein in transudates because the capillary permeability is normal, and that keeps proteins in the capillary fluid and only allows fluid to pass into the pleural space. And shown over here is a flow chart from a textbook you can look at if you want. It basically shows you Light's criteria right here. If none of the criteria are met, then you have a transudate, and these are some of the causes. If at least one of the criteria is met, then you have an exudate, and these are all the potential causes here. So let's talk briefly about thoracentesis, which I just mentioned. This involves a needle insertion into the pleural space. One reason to do this is to obtain a pleural fluid sample for diagnosis, but you can also do this to drain large effusions, especially if they're causing symptoms like shortness of breath. And then remember what I said before, for transudative effusions, we often, not always, but often treat the underlying cause. So for example, if it's a transudative effusion from pulmonary edema from heart failure, we will give diuresis. Exudative effusions, on the other hand, often require drainage, and that's because you've got capillary leak going on here. Bacteria can sometimes get into that exudative fluid, and that can lead to development of an empyema. The main complication of thoracentesis, incidentally, that can happen is a pneumothorax, which we talked about earlier. If the needle is advanced too far, it can puncture the lung, and then after you've drained the fluid, the patient can have a pneumothorax. Okay, so exudative and transudative effusions are the two major types of pleural effusions, but there are some other less common types, so let's talk about those now. First, we'll talk about lymphatic effusions, which are sometimes referred to as the presence of a chylothorax. These effusions are caused by lymphatic fluid accumulating in the pleural space. And this happens when there's some problem with the thoracic duct, which drains lymph fluid through the chest. It could be obstructed, it could be injured or damaged, whatever the cause. If it's not draining lymph fluid, that fluid can accumulate in the pleural space. The most common cause is some type of malignancy obstructing the thoracic duct. This can also happen due to trauma, especially post-surgery. Sometimes the thoracic duct is accidentally damaged in surgery. And the key characteristics to know about a lymphatic effusion is, first of all, that the fluid will look milky white like this, which is very different from the sort of clearish brownish fluid you get in other types of effusions. And then the triglyceride levels are usually very high. Triglycerides over 110 in the pleural fluid usually indicate the presence of a lymphatic effusion. Some other types of effusions are shown on this slide. A hemothorax is a pleural effusion caused by the presence of blood, like shown here in this cartoon. Key findings are that the pleural fluid sample will be bloody and there will be a high hematocrit in the fluid sample. I mentioned an empyema before, but an empyema is an infected pleural effusion, so the pleural fluid has become infected. These are common in patients who have pneumonia, who develop parapneumonic effusions. Those patients have bacteria in their lungs causing pneumonia, and once they develop a parapneumonic effusion, the bacteria can sometimes spread into the pleural space. Key findings here are that the pleural fluid sample will have pus in it. It can have a putrid odor from bacteria. And when you send it to the lab for culture, the culture will be positive. And then lastly, malignant effusions are effusions caused by malignancy or cancer. Many patients with lung cancer develop these. Key findings here are, first of all, that the patient may have a history of lung cancer. And also, if you send the pleural fluid to the lab and they perform cytology, they will find malignant cells in that pleural effusion fluid. And then I'll finish with one slide on mesotheliomas, which are pleural tumors. The only known risk factor for this pleural tumor is exposure to asbestos. Asbestos exposure occurs in workers in certain industries, and decades after they've been exposed, they can develop this pleural tumor. Because it's a pleural tumor, on imaging, what you usually see is thickening of the pleural and the presence of a pleural effusion. Patients usually present with a slow onset of symptoms like dyspnea, cough, and chest pain. These are all related to thickening of the pleura and pleural effusions developing. And overall, mesothelioma has a very poor prognosis. The median survival is 4 to 13 months if it's untreated, but even with treatment, the survival is usually about 6 to 18 months. And that concludes our module on pleural disease.